Okay, hi everyone. Thank you for joining us today for the NCID World AIDS Day event. My name is Arun and I'll be your MC. In this event, we'll follow a character named Jason through his journey as someone who has been living with HIV in Singapore for the past 5 years. This includes when he was first diagnosed, how his HIV was managed, and how he is now living well with HIV. Unfortunately, stigma and discrimination against people living with HIV still exists even within the healthcare setting. This is due to a lack of knowledge about how to care for patients with HIV, as well as a fear of contracting the virus. Through this event, you will learn the basics of HIV, the effects of stigma and discrimination on patient care, as well as what we can do as healthcare providers to combat it. We have an exciting lineup ahead, which includes some interactive poll sessions to get you involved in decision-making about caring for someone living with HIV. Now, to start off today's event, we would like to share with you a video co-produced by the Singapore National Employers Federation and NCID. This video aims to increase understanding and fight misconceptions about HIV in the workplace. After that, Dr. Wong Chen Seong, the director of the NCID Clinical HIV Programme, will provide the welcome address.
Okay, thanks so much, Arun, for showing that video. And thank you everyone for joining us and calling in. It's that time of the year again, 1st of December is World AIDS Day, and it's been nearly 4 decades. In fact, it's been about 4 decades since the first cases of what was eventually to be called AIDS were first being diagnosed in places like San Francisco, Sydney, and in London. And of course, soon after, HIV was discovered to be the cause of this disease. The theme for this year's World AIDS Day, as determined by the World Health Organization, is actually End Inequalities, End AIDS. And in the past few years, COVID has really taken over the world, and it has highlighted the inequalities that continue to drive the COVID pandemic. Access to healthcare, exposure to risk factors, availabilities of treatment and vaccines. Now, the thing that we have to remind ourselves of is that many of these inequalities, whether they are inequalities on a global scale or on a micro, societal, or even individual level, are also drivers of the ongoing HIV pandemic. I, remind myself and people around me that Omicron may be the word of the week, VTL may be the word of the month, vaccine may be the word of the year, and COVID-19 may be the word of the decade. But HIV remains relevant and prevalent, and it's a word that we should not forget. And the 1st of December is a good day for us to do that, this remembrance. Now, that's actually the reason why we have events like this. It's important to keep talking about HIV. It's important to recognize and remember not only those that we have lost to the disease, but also to acknowledge and celebrate, the quite bright future that we have in HIV. Things like highly effective antiretroviral therapy, things like undetectable equals to untransmittable, the ongoing research into cure and vaccine, but most importantly, to celebrate the lives of those around us who live with HIV, right? They are our friends, our family, our partners and spouses, our patients and clients, our colleagues and acquaintances. So this year, in addition to what we are doing today, this NCID Clinical HIV Programme's World AIDS Day celebration, there are also a number of efforts ongoing throughout the next couple of weeks to months on a national level. We have the Singapore HIV Congress, the second Congress that we are organizing by the National HIV Programme. The second day of this conference is this Saturday. You can still, if you'd like to join, registration is closed, but it is free. Just let us know, we can get you in. There are a couple of destigmatization campaigns that are fronted by NCID as well as the Health Promotion Board. Some of you may already have seen these posters up at the MRT stations at Novena. It'll be coming up to other MRT stations, bus stops as well, featuring some of our, one of our own patients. NCID Facebook is up and will soon feature HIV-related content. And there are a number of NCID-fronted videos, some of which you'll see today, and we'll give you the link to share them with your friends as well. We will be following, as Arun said, the journey of a person living with HIV as he navigates through the sometimes very confusing journey of living with HIV, focusing on how we as healthcare workers can guide him along the way. We'll be talking to a few of our colleagues, testing their knowledge, and eventually speaking with somebody who's actually living with HIV himself. Now, most of us who are on this call today are healthcare workers, and I've always believed and tried to share my belief that as healthcare workers, we have a privilege and a unique responsibility of walking this journey with our patients while living with HIV. And it's a duty that we should not take lightly. So over the course of this short lunchtime event, I hope that will give you something to think about, and that this little thought, right, that you walk away from, or idea that we share with you, maybe a spark that can light the lantern that can guide you and your patients on this journey of living with HIV. So please enjoy this event that my team has worked really, really hard on. You may have noticed some closed captioning that's appearing on the bottom of your screen. We're trying out a new feature for accessibility using this automatic live captioning feature on Zoom, so that we can share this event with our friends who are deaf and hard of hearing, and hopefully move this attempt to reach more people into the future as well. So thank you very much, and I'll see you later on in today's event. Thank you. Over to you, Arun.
Okay, thank you, Dr. Wong. I do agree that we can stop the spread of HIV by correcting the misinformation and creating an inclusive environment for people living with HIV. Now, to start off the first chapter of Jason's journey, allow me to invite senior staff nurses, Nathan and Tiao Shen, who will lead us through this segment. Nathan and Tiao Shen, whenever you're ready.
Thank you, Arun. Good day, everyone. My name is Teo Xuan, and this is my friend Nathan. We are both nurses working under the Infectious Diseases department in the NCID, and will be the quiz master for this section. I am sure you have enjoyed the lovely snippet by Dr. Wong. I hope you have digested the content, as some of the answers for this section were reviewed in the video. We will now proceed on to a short quiz session. First, could we request everyone to scan the QR codes flash on the screens, fill in your names and your institution. We strongly encourage participation in this quiz as there's much to learn about HIV during today's webinar. We will now give you some time to sign into the quiz. Okay, so without further ado, let's commence with our quiz. Wow, okay. Question number 1. Who should be tested for HIV? Men who have sex with women only, men who have sex with men who have sex with men only, or anyone who is sexually active. Okay. Time's up. So let's look at the answer. Okay, great. Everyone got it right. So the correct answer is D. Anyone who is sexually active. It is recommended that everyone between the ages of 13 to 64 should get tested for HIV at least once in their lifetime. Also, anybody who is sexually active should get tested for HIV regularly together with other STI. So let's move on to the next question. Aden, please.
Thank you, Chua. Okay, so everyone, for question 2, why is it important to test for HIV? To gain early access to treatment, to continue high-risk behaviors if I'm considered safe from HIV, to prove that a person is capable to work. Okay, there's another 10 seconds for everyone to answer. I wonder what the answer will be. Great. Almost everyone got it right. So the answer is actually to gain early access to treatment. Because the earlier HIV is diagnosed, the earlier one can seek necessary treatment known as antiretroviral therapy, also known as ART. And this is not the COVID ART, And ART helps people living with HIV to achieve viral suppression, which means a low viral load, as well as to boost your immune function, which helps them achieve a healthy life. This is also why we as healthcare provider, right, should encourage anyone who is sexually active to get screened for HIV. Okay, for the next question, I'm handing it over to Chua. Chua, please.
Okay. Question number 3. So why do people shy away from getting tested? Fear of results, fear of being spotted in a clinic or setting when testing for HIV is predominant, being judged for being tested, for example, promiscuous, like you have many boyfriends, you have many girlfriends, or you have many of both, drug user, or all of the above. Okay, great. Majority of you got it right. So the correct answer is all of the above. The misconception about how HIV is transmitted and what it means to live with HIV cause stigma and discrimination. This often leads to negative value judgments such as being promiscuous, being unclean, or being drug user in the society. Okay, let's move on to the next question. Adam, please.
Okay, so for the 4th question, it's a very deep question. And also important, is HIV a death sentence? True or false? Okay, there's another 8 seconds. Great. I'm glad everyone answered false. So it's right, it's false. Because advances in medicine now has ensured that people living with HIV are now living longer and healthier lives. And it's that to be on par of someone without HIV. This is contrary to the images that we see of HIV when the virus first emerged in 1980s. Okay, now let's see how everyone has been doing. Can we go to the next slide? Great, YK, you're winning. Okay.
Congratulations.
Congratulations. For the next question, I'm going to hand it over to Chua.
Okay, question number 5. An undetectable viral load is when the amount of HIV in a person's blood, aka viral load, is so low that it is no longer able to be detected by a standard viral load test for HIV. B, someone who does not know their HIV status. C, a person living with HIV is cured of the virus. Okay, time's up. Okay, we're all here to learn. So the correct answer is A. The amount of HIV in a person's body, also known as viral load, is so low that it is no longer able to be detected by a standard viral load test for HIV. So because adherence to treatment lower the viral load of a HIV in a person's body to an undetectable level. So according to science, there's zero risk of passing on HIV to their partner at this stage. However, this does not mean that they are cured of HIV, as interrupting treatment would allow rapid replication of the virus. So this is why the message of undetectable equals to untransmittable is so important. Okay, let's move on to the next question.
Thank you, Chua. So for the next question, what is the main benefit of an undetectable viral load? A person living with HIV can stop taking their medication. A person living with HIV can live a healthy life with a normal life expectancy. A person living with HIV can no longer experience stigma. We have about another 13 seconds to answer. Okay. Great, most of you answered correctly. A person living with HIV can live a healthy life with a normal life expectancy. Basically, because with an undetectable viral load, a person living with HIV will have a small amount of the HIV virus left in their body that it can't be detected by a standard HIV viral load test, like what Chua mentioned. As such, the body's immune system, right, does not get overwhelmed by the HIV virus, which also enables them not to get sick easily. A person living with HIV who has achieved an undetectable viral load can also commence family planning with their HIV negative partners. U equals to U yet again. Now I'm going to pass on to Chua again to ask the next question.
Okay, question 7. Okay, you will need to take extra precautions when interacting with a person living with HIV. True or false? Okay, 2, 1, time's up. Okay, the answer is false. So HIV is only transmitted through bodily fluids such as blood, breast milk, semen, and vagina secretion. HIV cannot be transmitted through kissing, holding hands, hugging, or sharing of food or utensils. You can still have your steamboat with your family during the Chinese New Year. Furthermore, there is an exception, as people living with HIV with an undetectable viral load will not transmit HIV through semen and vagina secretion, which means that you can still have your family planning.
Okay. So for the last question, can persons living with HIV work in a healthcare setting? Example, nursing, allied health administration. Yes or no? I'm wondering what our healthcare workers will say about this. Great, most of you all said yes. Actually, that's true. A person living with HIV can be employed in these settings as long as they do not involve exposure-prone procedures. And the list of departments actually can be found in MOH's directive for the management of healthcare workers, medical, dental, nursing, and paramedicine with Hep B, Hep C, and HIV. However, even with this directive, right, people with HIV continue to face challenges working in the healthcare setting or getting a job there. So therefore, with this knowledge of U equals to U, we hope that in the future, there'll be more employment options for people living with HIV who want to work in the healthcare setting. Okay, now let's see who has won this quiz. Congratulations, Xavier Lin, for winning the quiz. 600.
Congratulations.
Very good, yay. Okay, so now we have reached the end of the quiz. We hope that you had the opportunity to learn more about HIV and what U equals to U means. We also hope that we have raised some awareness on the stigma and discrimination that people living with HIV face, and why people are at times even afraid to get tested, which is the first step. So should you have any questions, please ask in the Q&A tab below. We hope that after today, you will be able to open yourselves up to have continuous and meaningful engagements that seek to deter stigma and discrimination faced by people living with HIV. And also through this, we hope to provide a safe space for our patients living with HIV, especially in our healthcare setting. We also hope that by doing so, right, we'll be able to enable them to lead their healthy and fulfilling life, and also set out to do what they want to do. Okay, everyone, thank you for attending our session, and I will now hand it over to Arun.
Okay, thanks, Nathan and Tiaoshen. It is indeed true that people who may have HIV are unwilling to take the first steps to get tested due to negative value judgments, which may come off as stigmatizing and discriminatory, which is why a society without judgment is necessary to get people to get tested for HIV. Okay, next up, we have Dr. Choi Chiao-Yi, Deputy Director of the NCID Clinical HIV Programme, who will talk us through the next chapter of Jason's journey. Dr. Choi, please.
Thank you so much, Arun, for the introduction. Now, before I begin, and I hope everyone enjoyed the quiz earlier, I would like to invite you to view this video that's produced by the Clinical HIV Programme. This video is actually part of a series that depict the journey of a person who is diagnosed with HIV. The first video shows what happened when a patient first learns of their diagnosis. Please enjoy.
Positive.
Yes. I know it's a lot to take in at this point in time. Okay, positive. And one of the blood tests that we did is the HIV positive. Jason, I'm afraid I don't really have good news for HIV. The blood test that we did is the HIV test. I'm afraid I don't really have the blood test that we did is the HIV.
This cannot be possible. Why did I think that things were going to be alright? My family, they're going to be judged. They're going to judge me, my mom and my dad. What am I going to do? What am I going to do?
Actually, I wanted to ask,
Yes, sir?
does this clinic only treat HIV patients?
Oh, okay, no. We have other cases like dengue, hand, foot, mouth, chickenpox, MERS-CoV.
Usually at this first visit, what I do with patients is, just sit down, have a conversation so that I can find out a little bit more about what you're going through, what your health is like, answer any questions that you may have, and then after that, do a quick physical examination so that I have a good idea of what your overall health is like. Yeah, so usually for our patients who are diagnosed and come to see us for the first time, we'll always ask you to go and see the medical social worker. She is very trained in this field and experienced, because oftentimes when people are getting a diagnosis of HIV, something that can be quite life-changing, it really helps to speak to someone who may be able to offer some advice, give you some supportive counseling. There are numerous financial assistance schemes that are in place that can really make medication available and accessible and affordable. Yeah. So shall we go and see her now?
Yeah, sure.
Okay, come, let me show you where to go.
Okay, sorry, I hope everybody enjoyed that video. I'll now go on with the presentation. Now, this time our presentation for this Wednesday will be slightly different from the rest. We are having a game or rules of encounter throughout our presentation. Everyone will be expected to join us. For this particular section, you are the healthcare worker attending to Jason, an individual with a blood-borne virus. Throughout this journey, you can choose how to respond and care for Jason. Your choices will impact Jason's healthcare journey. I mean this. So everybody, do your part, play. Whoever the majority answer will be the path that Jason takes. So please choose wisely. And your current role is physician. Background, we have Jason, who is a 22-year-old male. He's an undergrad student at the Arts College. He was referred from the polyclinic to the hospital for disseminated herpes zoster. Otherwise, he has no significant past medical history and was otherwise healthy throughout his life prior to this. This is a photo of how it looks like. For individuals who are less familiar, this does look like herpes zoster and disseminated because more than one area has the rash. So this is the first question, of which you have to make the choice. Would you treat the herpes zoster and discharge him? Or would you treat the herpes zoster, take a sexual history, and offer HIV screening? I will give you some clues before you make your choices. So just to explain a little bit on who should be screened for HIV. It was mentioned already earlier, but all individuals above the age of 21 years old should be offered HIV screening at least once in their lifetime. In the context of Singapore, the only population that don't really meet this kind of like criteria are females above the age of 65 years old. And you may wonder, why is it that females above the age of 65 years old does not need to be routinely screened? And that's because when we talk about HIV screening, we're talking about, as a form of healthcare screening, you want it to be cost effective. And they found that cost effectiveness happened when the seroprevalence of HIV within the population is more than 0.1%. And in Singapore, only females who are above the age of 65 years old have a seroprevalence of less than 0.1. Therefore, everyone else should be screened. In particular, we especially pay attention to this group of individuals when we talk about initial screening. I divided them largely into three groups. One is medical conditions, special populations, and others. Under medical conditions, as you can see, tuberculosis is one of the conditions where we routinely screen, and that's because HIV increases the risk of TB by 20-folds, and the rate of HIV and TB co-infection in Singapore is estimated to be about 4.9%, so it's not low and everyone should be screened. So individuals who were diagnosed with sexually transmitted disease, individuals who have AIDS-defining illness or symptoms suggestive of acute seroconversion should be screened as well. And I'll go through what are these symptoms. All pregnant women should be offered HIV screening at each antenatal visit, and all individuals who have high-risk behaviors for HIV transmission should be screened. Everyone is fairly familiar with AIDS-defining illness, and this can be easily found online as well. The bolded ones are the very common ones that we see, including candidiasis, cytomegalovirus, retinitis, mycobacterium tuberculosis is also an AIDS-defining illness, PCP, as well as toxoplasmosis of the brain. In terms of acute HIV infection, so we are always aware about late-stage HIV and AIDS-defining illness, but actually during the early part of HIV infection, people do have symptoms as well. So this is actually a series that's done of 34 individuals that's newly diagnosed with HIV, and you'll find that the most common symptoms for acute seroconversion is fever, rash, and diarrhea. And I know what everyone's thinking, it's quite non-specific, and I'll go through that in a little bit. There can be other symptoms as well, such as myalgia and arthralgia, as well as swollen glands. In terms of sign, the most common one is lymphadenopathy, followed by rash. So I know what everyone's thinking, it sounds like dengue, and true enough, it does. We actually have done a study that's done between 2012 to 2015 by NUH Tan Tock Seng as well as Alexandra Hospital to identify seroprevalence of acute HIV infection among patients who have dengue-like illness in Singapore. So febrile patients who have 2 or more symptoms of dengue without having dengue test done were actually recruited and offered HIV screen. And out of the 140 participants that were recruited, 3 were identified to have acute HIV infection, and this gives a seroprevalence of 2.1%. Now, this is high compared to similar studies that's done, for instance, in US and Uganda. Over there, they use individuals who have symptoms suggestive of acute mononucleosis infection, which is also how acute HIV infection has been described as well. And generally, the seroprevalence in those studies quoted as 1%. And potentially why the seroprevalence is quite a bit high here is because it's a relatively small number of participants that's been recruited. But I think the main point of the study is to show that when you have an individual who presents with symptoms that look like acute mononucleosis infection or dengue-like infection, but your subsequent test does not suggest these, please do not brush them aside as just viral fever and just let them go home. It could be acute HIV infection, and if you don't screen it now, they might be diagnosed very later on, because most of the time they remain asymptomatic thereafter until the late stage of disease. So what about herpes zoster? People living with HIV are at high risk of developing herpes zoster, although with therapy, this incidence has declined, but the incidence is still high compared to the general population. So especially with young individuals who it's not the typical population to have herpes zoster, that should ring a few alarm bells. Besides, there are also other dermatological conditions that are associated with HIV, starting with the one on the left. We have seborrheic dermatitis. The palmar rash that you see is typical of syphilis. Psoriasis has also been known to be associated with HIV as well. And the picture on the right actually shows Kaposi sarcoma. Okay, now that I have given you a bit of a rundown and a few clues to help you along, please do choose on the poll what your decision will be. Okay, can we have a look at what everyone's answer is? Okay, very good. So treat the herpes zoster, take a sexual history. Of course, this is for World Day. And I will show you. If you choose this one, you explained to Jason that it's unusual for a man of his age without immunocompromising condition to get herpes zoster. You decided that you would like to ask a sexual history and offer HIV screening. By the way, in case anyone think that both options will lead to the same kind of answer, I'll just prove to you now that if you choose option A, what will happen is that you will just treat him and he goes away and he comes back 1 year later with PCP. So your choices really does play a part. So choose wisely. Okay, very good. So everyone decide that you would take a sexual history and offer HIV screening. Now, this is my next question. How would you take the sexual history? Would you A, just say, I need to ask you a few sensitive questions for your care. Do you have sex with men? Or B, I need to ask you a few sensitive questions for your care. Are you gay? Or C, I need to ask you a few sensitive questions for your care. When was your last sexual encounter? Are your partners male, females, or both? Okay, let's have a look at the answers. Okay, very good. Everyone chose C. Okay, so you chose C, and because of that, he's willing to divulge more information regarding his sexual history. So he had his sexual debut at 16 years old. He had a total of 3 partners in his lifetime, all males. He's the receptive partner of all 3 partners, doesn't use barrel protection during intercourse, and he does not exchange money for sex. You counsel him and proceed with HIV and STI screening. If you choose the other 2, just quickly to show you guys, what will happen is that he appears a bit stunned, but he will deny all sexual intercourse. So it is quite important for us on how do we take history, to be sensitive about it and not to judge patients when we are doing it. So usually you have to preface your question by saying that you're going to ask some sensitive question. Do not ask if the patient is gay or heterosexual. We do not judge behavior. You just want to know what the risks are. So you ask if the partners are male, female, or both. For MSM, patients may not understand insertive or penetrative partners. Sometimes we use colloquial terms to make it easier to understand, such as top, bottom, or flex. And also do not ask if they frequent prostitutes. We usually ask if money was ever exchanged for the sexual intercourse. Because you did the HIV screen, the results returned. Unfortunately, it is positive. Now, following the return of the positive result, Jason now comes back to the clinic. It is a busy clinic. On entering the clinic, you notice that a new staff nurse is at triage. And upon learning that this is a newly diagnosed HIV patient, she proceeds to put on apron and gloves before taking his vitals. And Jason looks visibly uncomfortable. Question, what would you do? Would you just leave it alone because you don't want to make Jason more uncomfortable? Or would you approach the staff nurse privately and explain to her that bloodborne diseases like HIV infection is not spread via contact, sorry. And so there's no need to wear apron and gloves. All right, let's see what's everyone's choice. Very good. So everyone chose B. See what happened. So you spoke to the nurse and you explained to her that her behavior can have negative impact on Jason's care. And you explained that HIV infection is transmitted primarily via sexual intercourse and does not require contact precaution. This is an important thing to know. So what we keep talking about stigma and discrimination. What are they actually? So stigma is an individual or society's negative attitude, opinion, or judgment about a bloodborne virus itself or on perceived behaviors and lifestyle of an individual with bloodborne virus. And then because of stigma, you have discrimination. Discrimination is the behavior that results of the stigmatizing attitude, opinion, and judgment. And why is it very important for us to address this again and again? And it's because of stigma and discrimination, patients will have disengagement in care. It forms a barrier to care because they are quite reluctant to engage, results in lower standard of care and poorer health outcomes. So Jason's still coming to terms with his diagnosis. You'll be starting him on ART. He will also be seeing the social worker and the pharmacist. However, before leaving your clinic, he mentioned that a dental clinic has recently rejected his request for an appointment after learning about his condition. What would you do? Would you tell him there's nothing you can do about it? Or would you listen to his concern, write him a memo and find alternative clinics that are able to provide the services he required? Also to contact the clinic that turned him away to feedback on their discriminatory practices. Let's see the choices. Very good. So everyone chose B. Let's see what happened when you do that. So Jason's disappointed, but glad that you've heard his concerns and he felt hurt. He's also grateful that you've done your best to assist him. Just in case you're curious, if you tell him you can't do anything about it, he's disappointed, he doesn't say anything, he accepts that stigma and discrimination will be a part of his life. He avoids visiting healthcare facilities unless absolutely necessary, and this has subsequent impact on his health. So since everyone chose B, I will now discuss this. Does stigma and discrimination exist in Singapore? So if you look at the series of survey that has been done, there has been improvement. So in 1987, when we interviewed healthcare workers, 64% of them felt that nurses are at a high risk of getting AIDS, and 71% of them felt that they have difficulties with the practices of a person living with HIV, and 80% of staff felt they would be upset if they had to treat PL HIV. Eventually, this improved in 1997 when again a survey was done of doctors and dental surgeons, where 80% of them agree that they have an ethical responsibility to treat a person living with HIV, but only 50% will do so if given a choice. So there's still a disconnect there, despite acknowledging that they have responsibility to treat a person living with HIV. If you look at 2000, year 2000, which interviewed 2,310 doctors, nurses, and dentists. It shows good knowledge among them. 98% of them said that HIV is transmitted via sex and the sharing of needles. But strangely enough, despite saying that, almost 60% of doctors, dentists, and nurses said that HIV is also transmitted via kissing. And regardless, despite saying that it's from sex or from sharing of needle, 65 to 76% of the correspondents still feel that people living with HIV should be treated in special clinics that's separate from persons without HIV, and really shows that actually discrimination and stigma still exist in our society despite increased knowledge of how it is transmitted. And this is still something that all of us will have to play a part in actually reducing stigma as well as discrimination. So in summary, I hope you have learned which patient population fits the criteria for HIV screening, or at least initial HIV screening, learn how to take a sexual history, and learn how stigma and discrimination can have a negative impact on our patient's health. Our patient will be off to the pharmacist soon, but before that, I'll hand this back to Arun. Arun, please.
Thank you so much, Dr. Choi. I believe as healthcare workers, we can all play an important role in reducing stigma and discrimination by offering support and speaking out to debunk myths and stereotypes about HIV that we hear from others. Next up, allow me to invite Rebecca Neo, Senior Pharmacist at NCID, to bring us through Chapter 3, Managing HIV. Rebecca, whenever you're ready.
All right, thank you, Arun, for the introduction. So before I begin my presentation, we will now have a short look at the second video in the series, highlighting Jason, the person who has been newly diagnosed with HIV infection, returning to the clinic to speak to his allied health professionals about living with HIV and to clear up some misconceptions as well as some concerns that has arisen alongside.
Hi Jason, how have you been?
I've been good actually. It's just that I have been looking around online and there were certain debates about what we can or cannot do as HIV positive patients. And I was wondering if I could get your clarification on the matter.
Sure. Yeah. So what are some of your concerns?
Is it true that if I shared cutlery with my family or I touched them, I would transmit the virus to them?
A lot of patients actually ask it as well. So no, it doesn't. HIV is not transmitted through like touch, physical contacts or saliva. So you can definitely share food with your family and friends.
What if I have an ulcer and then the food we share is like a burger, then so it's closer contact?
Okay, first thing first is, let's say you're on medication, right? Medication will actually help you to control your viral load. So once it is undetectable, it will not be transmissible.
That's great news. I feel more relief right now. Yeah, thank you very much.
So I think next you're going to see a pharmacist, is it?
Yes.
Okay, maybe I can walk you there.
Okay, sure.
Hi Jason, how's everything so far?
I've been good actually. I've been taking my medication regularly and I think it's been working.
Okay, that's good. So just to confirm, you're taking your blue tablet and your yellow tablet, right? And everything seems good, so we'll probably just see you the next time round now.
Okay, no problem.
So yeah, we'll see you next time then.
Okay, thank you so much.
Thank
Bye-bye.
you.
Okay, so now that we have viewed the video, we will start the presentation official. So previously, Dr. Choi has allowed you guys to assume the position of physician. Now, during my presentation, we will now shift gear. So you as attendants would now assume the position of Jason, the newly diagnosed HIV patient. All right. So for Jason's case, he has just exited the doctor's consultation room after his first clinic visit. He has also been told that he is starting on antiretroviral therapy, and he receives a referral memo from his doctor. So he will proceed to speak to the DAP pharmacist. So normally during the first DAP session, the pharmacist will sit Jason down and then explain to him the antiretroviral therapy. So usually we will set aside some time to first manage expectations with the treatment, meaning to say we will introduce some parameters that the doctors would likely have already gone through with the patient just to finalize and consolidate what he has learned from the doctor as well. Then we will go through the exact details about the medication regimen itself, including the dose, the frequency, how to take it with regards to meals, and whether there's any side effects to preempt. And then we will stress on the importance of daily adherence and whether the patient is consuming any other forms of substances, including other medications, any supplements, or any form of traditional herbal remedies. Then we will let them know whether there's any need for them to adjust or make any changes to their consumption of these substances before we can proceed with the therapy. Then Finally, we will usually go through the costing of the medicines wise and how they can go about financing the medications so that affordability can always be discussed with the patient with regards to the regimen itself. Okay. So after speaking to the pharmacist, Jason would then proceed to the pharmacy to fill his prescription for the day. So after collecting his medications, he made his way home. Jason would then plan to take his antiretroviral therapy after dinner. So because of the recommendation by the pharmacist, he decided to set some form of phone reminders on his mobile phone so that he can kickstart the habit of taking medications, because as we know, medication taking is actually not innate in all of us. We have to kickstart a habit in this sense. So he also keep the rest of his medicine supply in a locked cabinet, as the rest of his family is not privy to his new diagnosis. Okay. So actually, once he goes back home, as he continues on his medications, Jason encounters an issue. So he realized that it's been getting rather difficult to take his medications discreetly at home, especially since his brother, who is still schooling, is sharing a room together with him. So what do you think will be Jason's next course of action at this point in time? So you can go through the options and consider, if you were in Jason's shoe, what option would you best select so that it will fit your lifestyle, and whether this will be the most suitable option for you. So for example, the first one would involve revealing the diagnosis to his family, or at least to the younger brother who is rooming with him, or he can choose to alter the dose timing to a more convenient timing, for example, in the early morning or late at night after the brother has gone to bed, or he can bring along his medications alongside in his bag and consume them before he returns home. Or lastly, to limit medication taking by only taking the medicines when the rest of his family is not around. So we'll just pause here and allow you to go through the options and select the one that's most visible to you. Okay, so based on the poll results, we can see that it's quite varied. The majority of the attendants actually selected option 2. So perhaps we'll go through the options one by one. So during Jason's follow-up visit at the clinic, he shared what had happened at home with the DAP pharmacist. Okay, so if you have selected, for individuals who have selected option 1, I'll leave that portion to Verena to go through the option later. Okay, so for option 2 wise, Jason, who has shifted his dose timing to midnight after his brother had fallen asleep, mentioned that he actually missed a couple of doses here and there because he had fallen asleep without taking his medications in view of the very, very late timing. Okay, so on our end, the pharmacist advised Jason on how to replace missed doses. So alternatively, he can also keep track of his adherence better by supply tracking, checking out his physical supply in the locked cabinet, or in the form of a weekly pill box, or calendar marking on his phone after taking the medication. We also advise him to adjust his phone reminders to match his dose timing now that it's right in the middle of the night, whereby the dose timing that he initially set was early in the day post dinner. Then whereas for individuals who have selected option 3, Jason has chosen to pack his medications and take them outside of the comfort of his own home. But he also lamented that this is rather unsustainable, because it is garnering a lot of questions from his colleagues whenever they notice that there's medication packets or even drug labels inside his bag, and he always have to hide in one corner to consume his medicines, which appear a little suspicious in that sense to them. So it's bringing up some workplace stigmatization for him as well. So the possible advice for Jason on this case would be to consider bringing his medications in a less conspicuous packaging. So for example, when he collects the medications at the pharmacy, there's always the option to opt out of the physical packaging of the medication packets, remove the labels, or he can even place the medicines inside reusable containers, for example, like mint, Eclipse candy, hard candy boxes, so that he can take his medicines on the go without appearing too ostentatious in that sense. Okay. Then whereas lastly, for individuals who have selected option 4, Jason tends to skip on his medications on the weekends because his brother, who is schooling, would be at home majority of the time revising of his schoolwork. So for this case, we would definitely have to explain the consequences associated with intermittent medication taking. So what are the possible consequences when he does not remain adherent? So we would advise the patient to also consider alternative options like the ones that we've gone through. So by and large, this would probably be the option that is the least favored. Okay. So moving on ahead, Jason subsequently remained rather adherent with reviews at the clinic for the next 1 to 2 years until one day he decided he's off medications. So he returned to the clinic for a visit and he shared with you what had happened. So he told you that actually he has decided to give his body a break from medications and stop them for 1 week as a trial first. Then after that 1 week trial, he felt that, hey, I was still completely fine, even without any medications. So he has stopped it for the total duration of 6 months since the last clinic visit. Okay. So upon hearing this, the DAP pharmacist would actually have a few things to consider. So the first thing would be to decipher what has Jason provided to you during your conversation. So addressing potential concerns. So why did he even want to stop and give his body a break from medications? Was there any form of side effects, any form of pill fatigue? And then what we can do to better address it. Then there could also be a clarification of possible misconception, explaining that the benefits of medicines may not necessarily be physically observable, meaning when you're taking medicines, you might not feel the benefits of it. And the converse is true as well. When you stop the medicines, your body might not immediately become weakened, but in the long run, there are still devastating consequences down the road. Okay. So after noticing this, the DAP pharmacist reviewed Jason's case and brought it up to the physician. And we started him on an alternative regimen, which is more manageable for him. For example, something that's more convenient, like a once daily regimen that has no food requirements, meaning he does not need to pair it with meals. And the cost is also rather acceptable for him as a young student. And the side effect profile, it still sits well with him to a large extent. Okay. So eventually down the road, if let's say Jason continues to be his adherence is still a bit wavering in the sense that he finds it difficult to take it on a daily basis, because truly the fact that he's still staying with the rest of his family makes it difficult to consume the medicines. And when he's still doing his part-time work, he's unable to bring out the physical supply with him. There are a few options that we can explore. So we can do this thing known as the directly observed therapy, whereby for Jason's case, we can keep his medicine supply at the pharmacy, and before he goes to work, he can drop by the pharmacy and physically return to obtain his medicine supply from us to take the medications before going to work instead. So something like that. An alternative option could also be the form of message or call reminder, such that we can encourage Jason to remain adherent on a daily basis without fail. So this is the end of my presentation. So I'll pass the time over back to Arun.
Thank you, Rebecca. So ensuring that a patient is adherent to medication is important in achieving an undetectable viral load, which would further prevent the spread of HIV to their partners. Remember, U equals to U, undetectable equals to untransmittable. Next up, I would like to invite senior medical social worker Verena Tan, who will be interviewing a person living with HIV on his experiences with living with HIV. Verena, please.
Hi, thanks Arun, for the introduction. Hi, good afternoon, everyone. I hope you're enjoying the session so far. So no presentation from me today. We're going to do a short interview with a very special guest of ours. Before we begin, I just thought I'll share a little bit about what social workers do here over at NCID, in case some of you may not be very familiar. So together with a team of colleagues, we provide psychosocial emotional support to our patients. And sometimes if there is a need to, we also do facilitate sessions if patients would like to disclose their diagnosis to their family. And I think in the video, first part of the video, in Jason's video, Dr. Wong shared a little bit about what what we do, right? So other than the psychosocial support, we also do provide financial assistance as well if there's a need to, for our patients who are not able to afford. And also for patients who may have issues with care needs, we also help with care planning as well. So receiving a news that you have HIV, it's not easy, right? It has been very difficult, for some of our patients. And how well they cope, often is tied to how well supported they are, whether if it's from their family, from their friends, from their colleagues, or even their organization. And often our patients, sometimes carry with them this sense of guilt, and also a lot of shame, at having to live with, HIV. And so stigma and discrimination has a big part to play actually in how well our, patients cope. So maybe before we begin, we can take a look at part 3 of Jason's video.
Yeah, I can't wait.
Hey everyone!
Hey Jason!
How are you guys?
Good.
Let's hang out.
We are hanging out now.
Yeah.
Okay. Yeah. Thanks, Arun, for the video. So living with HIV, I think it's also important to remember, that having HIV does not make you less of a, you can still be a good son, a good daughter, a good friend, and a good colleague, Perhaps let us then hear, from Adrian, our special guest today, what it means, to actually live well with HIV. So, hi, Adrian.
Hi,
Can you
hi
hear me?
everyone. Hi Verida. Yes.
So before I begin, I just really like to thank you, for coming here with us, today. I think it's not easy to find someone who is, so willing and open to really just share your, story and life with our audience here today. So thank you very much. Before we begin, perhaps you could share with us a little bit about, how you came to know about your diagnosis, when you were diagnosed.
Okay, so I was actually diagnosed in March 2016. So that's like 5 years ago. So there was a free test campaign going on by EFA. So I actually went to the anonymous testing service by EFA at Kelantan Lane. So I actually went with a friend to get tested.
Okay. So that was about 5 years ago. What was it like for you then?
So the day before I got tested, I actually have a friend who works at EFA at the point of time. So I actually told him, if it's positive, can you be the one, delivering the results to me? So when it, my turn, my number was called, and I went inside the room, and the first thing I saw was him sitting down on the chair. So my emotions at the point of time, everything, my surrounding, just the video, the first video just now, like my surrounding turned actually pitch black, and I feel like, everything was like collapsing. So the journey back home on that night, it felt really scared and scary. There's a lot of thoughts in my head, And I was, when I got into the bus, I was like crying. Yeah, so when I actually reached home, everyone was asleep, and the first thought, I just went inside the room, and it was, pitch dark and everything. So I was having like suicidal thoughts in my head. So without thinking further, I just, went to the window and actually stick out my leg out of the window. And just nice, a close friend of mine whom I was texting when I was on the way back text me, and I was telling him like, I was, about to, end my life. So he was, sending words of encouragement to me, saying things like, you have, you have come a long way, and there's a lot of support for you out there. So don't give up on life. Yeah. So it was really touching for me that, I had someone at a point of time. Yeah.
Okay, yeah, I think, yes, thanks for sharing. I think it's really not easy, receiving news as such. And I think many, perhaps not just you, I think, our newly diagnosed patients also, do share that, thinking about suicide is not uncommon. Yeah. So it's nice to know that, there had been some support for you, yeah. For some of our patients, I think sometimes they also share that, they feel that, the world has come to an end, some of the hopes and dreams that they actually have, like, perhaps they can no longer fulfill, so that's how some of them feel. Yeah. So now that it's, 5 years on, yeah, I'm just wondering how are you doing with regards to living with HIV?
I would say, I'm much more stronger compared to like 5 years ago. Like for my family, I was never close to my family ever since young. And my dad left us when I was only 8 years old. So my mom actually raised us 3 kids single-handedly. So my mom remarried and actually moved a lot growing up. So I stayed with my grandma, stayed with my mom, and I actually shifted out as well. So back in like 2016, I was actually staying with them. So I actually took one day to, decided to actually tell them that I'm HIV positive. So actually, I was in the living room. Then I was like telling my siblings first, that I'm HIV positive. Then after that, they are concerned, using the doctor and stuff like that. So I went inside my parents' room. My mom and my stepdad was in the room, and I just told them that I have something to tell you. Like, okay. Then after that, they said that, okay, so what is it? Then my mom just kept quiet. I think she sensed something was, something bad that I'm gonna say. Then after that, I just told them like I'm HIV positive. So my mom just kept quiet, but my stepdad was, saying unnecessary remarks. He was saying things like, you should have been dating girls instead, dating women instead, or else you won't actually, this wouldn't have happened. Yeah, so I was actually extremely hurt at point of time, and my mom started to talk. She actually asked me how I'm feeling. Am I seeing the doctor? Am I taking medication? Yeah, so after that, my dad actually said that, you will need to separate your utensils, your cutleries, your shavers, and everything away from your siblings. Yeah, so as this goes by, I educate them about HIV. HIV doesn't transmit that way. I even brought back, because they are not very well versed in English, so I actually brought back a booklet in Malay about living well with HIV. So like fast forward till now, I'm back staying with them, and they check on me every now and then, asking me if I'm seeing the doctor regularly, taking medication. Yeah. So because of my, when I actually told them that I'm HIV positive, right? Like, things like, vaccine, COVID and all that. So I'm like, the doctor in the family. So anything medical, they would actually ask me with regards to medical stuff. Yeah. So, being 5 years ago, like till now, it's been quite a challenging journey, I would say, without the support from colleagues, friends, whom I call family. I think they are here today. I'm able to be where I am today. Yeah, and I'm grateful for that.
Okay, wow. So I hear that actually it was not easy for your family at the start, right? To actually learn of your diagnosis, but somehow, along the way, they managed to provide the support you need now. Yeah, I'm just wondering, what do you think could have, kind of caused that shift, in terms of, how your family responded? Like you mentioned that, they initially wanted to separate utensils, and all.
I think they was afraid that I would, pass it on to my siblings. Yeah, but they are not really well versed with HIV, which I feel that everyone, like regardless of sexual orientation, gender identities, should at the very least know about HIV, how HIV transmit lah. Yeah.
Okay. So that psychoeducation bit that you did with your family, you think that was helpful for them to, in a way, better understand what HIV is and probably kind of stem out some fears that they may have.
Yeah.
Right. Okay. Thank you. Yeah. So I think just now Rebecca mentioned, during her poll, right? Like question 1, some of them chose to disclose their diagnosis to family, right? Yeah. But I think in your case, Jason, I think you're really fortunate also and blessed, right? That family is very accepting at this point. Unfortunately, we do also have some patients who may have disclosed their diagnosis to family and have been chased out of their house, or whose friends have cut off contacts from them. Yeah. So it is very challenging, I think, for patients to consider disclosure to family unless they are certain that family is going to be supportive, or they would at least get some support from family or friends. Yeah. So perhaps at this point, I'm just going to take a short poll from the audience, to just hear from them. Say, for example, I mean, since we're doing it in the healthcare setting, right? Say, for example, if one of your colleagues were to disclose their diagnosed HIV status to you, what would you do? Yeah. So just to hear from your opinion or how you feel, if one of your colleagues were to disclose, what would you do? You want to find out what happened? You would be more careful in your interactions with them, or I would check if they need help, or I may tell my colleagues or supervisor or boss. Okay. Yeah, so I think majority would generally check, perhaps being healthcare workers, right? We would generally check with, our fellow colleague to see if they needed help. And perhaps maybe in the process, yeah, sometimes you would want to, ask what happened. But I think more importantly is to see what kind of support they need, right? Yeah. And perhaps maybe then we could hear from Adrian. How about for yourself? If how would you have liked to be supported, if you were to disclose your diagnosis to your colleague?
I think for myself, because I'm working at AFA, but if I'm not working at AFA, right, I wouldn't disclose my status to my colleague unless I'm really close with, with the person. Yeah, so I think there are some things that, everyone should take note of when, someone decides to disclose their status to you. Like some things that you should not say will be, it's a common question. How did you get it? Yeah, because like, I don't know, like why people are so curious, like how do you get it and who gave it to you? Are you going to die soon? That kind of questions. I feel that, it's quite insensitive and to actually ask that question. So the things that one should say, thank you for sharing with me. I appreciate you telling me that, because it is not easy for someone to, disclose their status to you. So basically just, say comforting words. If you're not sure, then, go to organization like AFA, NCID, yeah, so it is not easy for someone to disclose their status to you. When they do, it means they trust you. Yeah.
Yeah, I think you said it. So sometimes perhaps it's very human, right, for us to want to find out, oh, what happened, how did you get it, and all, but rather maybe as a patient, what you would really want is, how can I support you, how have you been, what type of help do you need now, right? Yeah, okay, thank you. So I'm just wondering, Adrian, since we're on this, whether if you had experience or incidences where perhaps you did not actually feel very supported, yeah.
I faced countless, discrimination for the past 6 years, because I'm actually publicly out. So on social media, when I saw my articles, there's a lot of, unnecessary negative remarks, but I kind of like, grew out of it. And, things like dating apps, workplace, and also healthcare settings. Yeah, so when, for healthcare settings, I've heard things about, my peers who are living HIV actually went for the vaccination, and the staff there was like openly saying and asking like, are you HIV positive, in front of everyone, and there was a lot of people surrounding him. Yeah, so like for myself, like workplace, I did work for this company before, and actually didn't actually disclose my status. So I was thinking of doing interviews, and I'm just afraid that you would actually see my articles online. So I decided to tell my hiring manager that I'm HIV positive. So he actually wanted to terminate me via text. Then I told him that I think we should meet up. So at the point of time, I wasn't working at EFA, so I actually got one of the staff to actually go along with me to see the hiring manager. Yeah, so to cut the story short, they actually gave me a termination letter, two choices, termination letter, saying that, I wasn't being honest, that I'm a HIV carrier, or I'll actually write down my own resignation letter. So I actually chose the termination letter. And it was quite an unpleasant journey for me at that point of time. And I was telling my, the staff from VFA at the point of time that, it's quite exhausting, and I just want to get it done and over with. And even up till this day, is still at the back of my head. Yeah.
Okay, well, that must have been very, very unpleasant to have to experience that. Yeah. And actually, I think you are not the only one, here and then, even like recently, we have also heard, of a patient who was actually offered a job, it's one of my colleagues' case. And then, after disclosure of diagnosis, it didn't go through, right? Yeah, so it is still very real, I think this topic of discrimination at workplace, in our society today, and perhaps more can be done, yeah, for our patients, yeah. So how is the current workplace now for you then?
I would say, because I'm working at EFA, my colleagues are very awesome. I think they are here as well. They're very supportive. So we are like a very close-knit family. So everything if I were to struggle with my, status, or just need some emotional support, I would just turn to them. Yeah.
Okay. Yeah, it's so different, isn't it? If we're able to be working in an environment where you are kind of accepted for who you are, right? And being valued for your competency, your capability instead of what you have, right? I think that would be so nice for all our patients. Yeah, and I think sometimes perhaps, as humans, we may not realize, the stigma that attached by the actions and the words we use now. Yeah. So I am wondering, perhaps Adrian, whether if are there do you have ideas or suggestions, perhaps what we could do, to help reduce stigma or discrimination, yeah, at the workplace or just in general?
Yeah, so like I mentioned just now, up to this day, 2021, people are still thinking that HIV is a gay disease. So everyone, regardless of sexual orientation, like I mentioned just now, should educate themselves about HIV. And it's already 2021. HIV shouldn't be a taboo topic to talk about. So if you can talk about, actually you must talk about HIV in your work, social settings, your family settings, so that if someone were to actually diagnose positive in your work or social settings, they can actually turn to someone and to have support. Yeah, and especially in healthcare settings, anyone who is newly hired, I feel that they should undergo training with regards to HIV. Yeah.
Okay, so perhaps like some awareness, right, and also
Mm.
some sensitivity training workshops would be helpful.
Yeah.
Right. Okay. Yeah. So I think truly, really, stigma and discrimination has such a big impact, with people living with HIV. And even though we are healthcare workers, but we are also humans, and sometimes we do have our own set of values that we carry with us. And HIV, they say it's very much a social illness, right? It's not HIV that kills, but sometimes it's the stigma that kills. Yeah, and I think if we can deal with that, I think that would really help. Yeah, people living with HIV. And perhaps maybe for us as healthcare workers, I think it's to remember that people living with HIV are actually just like you and me, right? Yeah, and that we, you have your own skills, your gifts, your talents, and that they can continue to contribute to the, to their family, to society, to their organization, yeah, at large. Yeah. So I think the question, for me is whether can we support people like Adrian? The choice is yours. Yeah. So thank you very much, Adrian. Do you have anything else to add before we wrap up?
Not really. I think I just want to say, like, just be kind to everyone, regardless whether they're HIV positive or not, lah. Because we are kind of like living in a very trying times now, right? Yeah. So just be kind to one another. Yeah.
Yeah. I think the world can do a lot with people, who are kind to each other. Yeah. So thank you so much, Adrian.
Thank you.
For your time, Yeah. And so we'll hand it over to Arun. Yeah. Thank you.
Thank you so much, Verena and Adrian, for the honest sharing of your experiences living with HIV. Indeed, HIV is no longer a death sentence. With early detection and treatment, it is possible to lead healthy and fulfilling lives. Remember, U equals to U, undetectable equals to untransmittable. A person living with HIV with an undetectable viral load will not be able to pass the virus to anyone else. With that, allow me to invite Dr. Wong Chen Xiao once again to walk us through the last chapter of Jason's journey, beyond the first 3 90s. Dr. Wong, whenever you're ready.
Thanks so much, Arun. And I just wanted to sort of thank Adrian again for coming on and sharing with us. I think it always is such a privilege and such an honor for us to hear the quite personal life stories and experiences of somebody who's going through or who's gone through such experiences, I guess, in your life. So I am going to sort of close out today's sharing. And for those of you who are still here, thanks for staying to the end. I'm just going to go through quickly, just in a sense, what's the next step, right? We've talked about diagnosis, we've talked about starting treatment, we've talked about getting healthy and living with HIV. And what I want to maybe carry the conversation forward is, where do we go from here? For such a long time, we've thought that getting people to an undetectable viral load was the goal, and after that, everything's sort of fine. But what I'm here to maybe talk about is that, do we need to look beyond the third 90, and how do we do that, and what are some of the things that we need to think about? Now, I'm going to go quite quickly in the interest of time, but once again, if there's anything that you would like me to, you'd like to ask or talk to us a little bit about, even beyond today's event, just feel free to reach out to us. Now, I showed this slide quite frequently after I found it in a Lancet article earlier that was published in 2017, that really talked about the eras of HIV as being divided into 3 main ages, right? The first decade, from the 1980s to the mid-90s, were known as the age of devastation, when there wasn't any treatment and people were essentially getting sick and dying very frequently from HIV/AIDS. Then the middle decade, from 1996 onwards to the early to mid 2000s, was what was known as the age of discovery and action. That was where the protease inhibitors came onto the scene, when antiretroviral therapy in combination really started to change the landscape of what HIV was like. People were starting to get their viral loads under control, their CD4s were recovering and starting to live healthy lives, and no life expectancy of people living with HIV started to come towards what we now almost take for granted, that it can be essentially normal. And the the mid-2000s to where we are now is really the time where we are realistically starting to discuss and talk about the end of HIV or the end of AIDS. And what we may not mean by this is not, perhaps not at the moment complete eradication in the way that we have eradicated smallpox, but really about moving HIV and AIDS away from being a global public health concern, which it still remains now, but recognizing that we have the tools and the ability to end it as a public health problem. We have highly effective antiretroviral medications that can render people virally suppressed, with great benefits, not only to their personal health, but to public health. They can't transmit it on to others. But, research is ongoing every day to find a cure and perhaps to find a vaccine as well. Now, what do we know about HIV global stats today? We know that thankfully the number of new diagnoses are going down. We know that the number of AIDS-related deaths are going down as well. These are globally. We also know that in Singapore, thankfully the number of new diagnoses are decreasing year on year, all of which are positive developments that we should really continue to work hard to ensure continue. Most of us here will know about the first 3 90s, the first 90 being that 90% of all people with HIV infection should be diagnosed or aware of their condition. 90% of these people should be on treatment, and 90% of people who are on treatment should have a viral suppression. And the goals were set by UNAIDS, right, the United Nations HIV AIDS Programme, to be accomplished by 2030. Now, we are slightly off track, or a little bit more than slightly off track. But many of us know this 1990, but don't really know why it's so important. Now, the thing is that if we achieve these targets, right, and we look at the blue line, which is where we wanted to be if we could achieve these by 2030, as opposed to the lines in green and red here. In terms of new HIV infections, if we do nothing, if we don't aim for 90, the number of new cases will go up. If we don't aim for 90, the number of AIDS-related deaths will go up over time. If, however, we do achieve these goals and we work hard towards them, then the number of new diagnoses and the number of deaths will actually decrease over time. Now, Singapore's performance on 90 has been pretty good, and this is data that's correct as of the data that was presented last year. So I don't yet have clearance to share with you the data that was presented just last Saturday at the 2021 Singapore HIV Congress, but you can see that we have achieved the first 2 90s of getting people on treatment and getting people virally suppressed. We do need to work a little bit harder on getting people diagnosed. But if we look at the trends over the years, we are improving over time in terms of getting people diagnosed, as well as people on ART and people on HIV with viral suppression. So having said all this, right, having congratulated ourselves for doing well on the second 2 90s and making steady progression with the first 90, begs the question, is there more to life than just the first 3 90s? I've got a poll question here. I don't know whether Arun can put up that poll. What do you think is the 4th 90? Is it good mental health? Good health-related quality of life? Good social support? Or good life expectancy? And I think we'll just give everybody a few more minutes, a few more seconds rather. And let's look at the results. Okay, so 54% of you said good health-related quality of life, and then about 23 to 15% said good social support, good life expectancy, and good mental health. Now, really the 4th 90, and those are all great ideas, but the 4th 90 really refers to good health-related quality of life, of which, of course, mental health, access to medications, and all of that fall into good health-related quality of life. So when did this whole concept of a 4th 90 start? It really started in about 2016, 2017, when a paper was published in BMC Medicine by Jeffrey Lazarus, who said that, we have taken for granted that people will get an undetectable viral load as long as we diagnose them and start them on treatment, because medications are so effective nowadays. But is that all there is that we can achieve? And that was where they introduced this idea of a fourth 90. That means ensuring that at least 90% of people who have HIV infection should have a good health-related quality of life as well. Now, we should not, however, think about health-related quality of life as only applying to people who are virally suppressed. So if we put this fourth 90 at the end, right, it seems to give the impression that only those who have viral suppression should we think about good health-related quality of life. So rather, we should think about good health-related quality of life for all people living with HIV, right, regardless of whether they are already diagnosed, regardless of whether they're already on treatment, regardless of whether they've already achieved a degree of viral suppression. I think as healthcare workers and as community workers, it is our responsibility to try to make life, as high quality and as good and as comfortable and with good access to all kinds of services as possible for all people living with HIV. Now, the question about quality of life, of course, is very complex. How do we actually measure quality of life and what do we mean by it? Now, the World Health Organization actually has a tool. It's called the WHO QOL, Quality of Life HIV Questionnaire. It's an instrument, actually, which covers 36 different domains, right? It's a very long questionnaire. It takes several, an hour and a half at least to do. And it covers things like physical health, independence, psychological health, spirituality and personal beliefs, social relations, and environmental health. So all the aspects that go into a well-rounded kind of picture. And I'll only be focusing on a few and just sort of bringing you through them and introducing you to them in the interest of time. Now, I saw a question in the Q&A just now about how faith-based organizations can come in to make life better for people living with HIV. And I think the fact that it is an entire domain in the WHO Quality of Life instrument tells us how important faith, spirituality, and personal beliefs comes into a quality of life. Faith-based organizations have always been part of the HIV response in Singapore, including things like the CARE, which is the Catholic AIDS response, including organizations like the Tzu Chi Foundation, all of whom provide financial assistance, as well as access to medications and spiritual support for people living with HIV, depending on what your faith is. So the answer to that is that faith-based organizations are crucial, are essential in making life better for people living with HIV, especially since in the past, there have been instances where faith and HIV or faith and the social behavioral aspects that increase the risk of HIV haven't always seen eye to eye. But I think we're in a place now where those conversations are improving, and we should continue to nurture those conversations and relationships. So the first thing about quality of life is, of course, acknowledging that people living with HIV are getting older. You can see from a European cohort that the number of people who are aged, let's say 70 and above, is set to grow with time. By 2030, we'll expect to see nearly 5 to 10% of people living in Europe living with HIV being aged 70 and above. And this is also reflected in the Asia Pacific region. So if you look at it over time, the group that is biggest, the darkest in red, is set to grow. That's the oldest group. The people who are younger, the proportion of people who are younger, which is in pale yellow, is set to decrease. So what this means actually is not surprising, because people living with HIV are living longer, right? Treatment is making them healthier. They are living normal life expectancies, essentially. So the group of people who are growing older with HIV is going to grow with age. And what this means also is that the number of comorbidities, that other medical problems, are going to grow older as well. And you see this in this graph. And compared to people living without HIV or without HIV infection, the likelihood of them having other medical problems like diabetes, high blood pressure, mental health issues is also growing. You can see as well that comparing 2003 to 2013, that's a 10-year period. The number of people living with HIV who have things like high blood pressure, high cholesterol, diabetes, kidney involvement, heart disease, and so on is also increasing almost across the board. Now, this just shows that people are living longer. These are age-related conditions. This was just globally. So this was a global look at it. In Singapore, my colleagues and I did a study as well, which showed that if we look at the group of people who are age 60 and above with HIV seeking medical care, NCID, almost 65% of them have high blood pressure, almost 60% of them have high cholesterol, almost 30% of them have diabetes. right? So all of this means that in order for us to make sure that they are living healthy, they've got good quality of life, we need to manage all of these other health problems as well. So managing the older person with HIV is complex and it's complicated and will require the involvement of a multidisciplinary team, which is why I'm so happy to see colleagues from nursing and pharmacy and social work and clinicians, of course, taking part in today's webinar, because we do need to take a multidisciplinary, whole person approach rather than just focusing on the HIV alone, recognizing that there's much more to ensure people enjoy a good quality of life. Now, we talked briefly about mental health, and many of you answered that mental health is the fourth 90. So the reason for this actually is that if you compare the general population in dark purple and the HIV people living with HIV in light purple, much more likely to have any psychiatric issue or mental health issue, much more likely to have things like depression and anxiety and even panic attacks. And people who have mental health issues, especially if it's not treated, are also much more likely to have poor adherence or suboptimal adherence to their antiretrovirals. So underlying how important it is for us to address mental health issues. Now, this is reflected in the UN AIDS and the WHO Sustainable Development Goals, right? Mental health has been highlighted as an essential part of ensuring the health of the global population as a whole, let alone people living with HIV. And addressing mental health really requires, once again, a complex multidisciplinary approach, where you want to pick up things like, worry, lack of energy and insomnia before it becomes a full-blown psychiatric diagnosis. And what we do here at NCID, I've got my social work colleagues here, but also together with the psychologists and psychiatrists, is integrate this with multidisciplinary HIV care, ensuring that people address mental health issues at every step of the way. Now, we've talked a little bit about antiretrovirals already, but medical care and the medications we choose also play a crucial role in quality of health. We know that the ARTs that we use very commonly have lots of different side effects, from things that are, a little bit milder, like weight gain and nausea and vomiting, to things that can be quite severe, like liver involvement, high cholesterol, neuropsychiatric side effects. Now, medications also come in different forms, right? We know that the lower the pill burden, the fewer the tablets you need to take, the more likely people are going to be able to take them regularly and take them daily. And in recognition of this, drug manufacturers are producing more and more single tablet combinations. They have 2 or 3 drugs just in one single tablet. Now, we talked just now that people living with HIV are more likely to have other medical problems, which means that they're also likely to take more medications. And HIV medications have been known to cause drug-drug interactions. And sometimes these interactions can cause either toxic effects or side effects, or reduce the effectiveness of either the HIV medications or the medications they take to treat their other conditions, or both. What's more, these drug-drug interactions can actually have quite severe effects on liver, on the kidney, on other organ systems as well. And our HIV medications may also require our patients to be aware of, whether they take it with food or without food, and so on, all of which can impact the likelihood of the patient taking the medications and can impact their quality of life as well. So the reason why I bring you through all this is because as physicians, as clinicians, choosing the right medications for our patients in the most appropriate way can have great impact on their quality of life. And I didn't even talk about cost yet, right? But that's something that, Verena and Adrian talked about just now. So my second and last poll question will be, how can we, which of the following does not help in the improvement of adherence to antiretroviral therapy? Choosing the best tasting medications possible, choosing multi-tablet combinations, choosing medications that have the fewest drug interactions, or choosing medications that have simple or no food requirements. Okay, I think let's close the poll. Okay, so does not improve. So maybe it was a bit of a trick question. So I think the answer here is to is that we should not be choosing multi-drug combinations, right? Because the more multi-tablet combinations, sorry, because the more tablets you have, the more likely it is that people are going to have trouble, taking them daily and in the best way possible. Best tasting medications, which was the answer that many of you gave, may not be something that we think about, but my patients do tell me that some tablets do taste a bit weird, and it has made them not want to take it before. Like Calitra, for example, those of you who either remember taking it or remember prescribing it, does have like a weird taste and causes a lot of diarrhea. So there are a number of medication strategies we can use, all of which will help our patients enjoy a higher quality of life. Now, the last thing, of course, is stigma and discrimination, and I won't be spending too much time about this because I think Adrian and Verena covered this very, very well. But I think, the previous director of UNAIDS said it best, which is that whenever HIV and AIDS has won, it has been because of stigma and discrimination and apathy. Wherever we have won the battle against HIV, is because we have battled against these stigma and discrimination. Does stigma and discrimination exist in our own healthcare system? I think there are a number of publications throughout the years to show that even at healthcare worker level, there's still some degree of lack of understanding and discriminatory behavior against our own patients who are living with HIV. And in fact, in last year's World AIDS Day event where we had a quiz, there were some people who still did not know that you could not get HIV from mosquito bites, you could not get HIV from individuals, shaking hands with individuals living with HIV. And we know that actually reducing HIV stigma, right, in the line in blue, can not only reduce it can actually, how do I put it? Reducing HIV stigma increases the likelihood of people doing things like using condoms and having safer sex, and gets people taking medications even better. All of which show you that what reducing stigma does is give you the correct environment for you to be able to wage an effective war against HIV with the hope of ending HIV in our lifetimes. So how do we get there? We provide high quality evidence-based HIV care with a multidisciplinary team. We focus on aging, having multiple medical conditions and polypharmacy. We measure quality of life in our patients, and that's something that our clinical program is going to be set to do in the next few years, and also increase education awareness and reduction of stigma and discrimination. All of you who are here today have done your part, in coming and attending this, and hopefully you'll continue to do your part by continuing this conversation about HIV and sharing with, maybe somebody who didn't attend today, one of the lessons, one of the things you learned today, even if it was, just a small little fact or a positive emotion that you had just by attending today's webinar. And I thank you very much for this. Arun, would you like me to move straight on to my closing comments?
Yes, please. Thank you.
Okay. So, I do thank you. We've run slightly over time, just about 9 minutes over time, but, I just want to express my deepest appreciation for all of you who attended and took, your lunchtime off. I hope that it was enjoyable, informative, and that you did learn something. I also wanted to thank my team and everybody who spoke today. So Chowie, Verena, Rebecca, Teoshen, Nathan, Arun, Sally, Lavinia for helping with everything. And of course, my deepest appreciation and thanks goes to Adrian for taking the time out to really come and join us today in this conversation. Thank you to everybody once again who joined. Today is World AIDS Day. You might see that there's lots of activity going on, maybe on social media and over the next few weeks as well. So, if you've never sort of clicked through those things and found out what things were, just do maybe take the time and take the opportunity to find out a little bit more about what all the fuss is about World AIDS Day. Please do give us your feedback as well by scanning the QR code here. And actually, all of the videos that we showed today are available on the NCID YouTube page. If you didn't know that there was an NCID YouTube page, there is. So go there. And I do encourage you to maybe share those videos because it's an easy way to get people to learn a little bit more rather than through like a telling way, just showing them what we mean. So thank you once again and have a great World AIDS Day 2021. Thank you.